start our COVID-19 experience webinar, a lens to inform the frontline. I'm being helped with co-chairing by Nontokozo Langwenya, and we hope you'll have lots of questions that you can either put in the chat or save to the end. We have a really exciting program, and we will have time for discussion at the end, but one or two speakers who might have to leave, we'll keep their co-presenters on for questions. So it's my real pleasure to start off. We're looking at a kind of lens from the front line as the epidemic evolves enormously now. We're gathering information, we're gathering data, and we have lots of research that we now have to rethink and look at our findings from the hub, but also think about what does this mean in the light of COVID. And we have some COVID specific issues that have come up. So that's our exciting program. We were quite interested to start off with a kind of a look at teen pregnancies, and a look from fathers as well as mothers. Very often, if you look at the literature on teen pregnancies, much of it is about preventing it. Don't let it happen, but it does happen. So we've got a bit of both in our papers, and it's my real privilege to introduce the first speaker, who's Professor Sarah Skeen and Dr. Aine Aventin, who are going to talk jointly on their study, which is a gender-transformative sexual and reproductive health intervention to prevent unintended pregnancy and HIV/AIDS for adolescent boys in South Africa and in Lesotho. So the floor is yours. Do you want to take over?
Thanks, Lorraine. I will. Hi, everybody. I'm going to share my screen. So let me know when you can see it. Is that okay?
Yes, we can see it. And if you put it in full screen, lovely. Go ahead, Sarah.
Okay, great. Thanks. And thanks so much for inviting us here today. So I'm speaking together with Aine Aventin, who is based at Queen's University in Belfast, about a project that has already started to some degree, but we're really going to be focusing on more in the coming 2 years. And it was quite an interesting exercise for me as well to sort of think about COVID and how, I suppose, how the project is going to be affected by COVID, but also how it's timely, I think, in many ways, given what's happening. Oh, no, I can't. There we go. So just to say, this is how we are approaching the presentation today. I'll just give you a bit of background on what the project is actually about. Then I'm going to hand over to Aine, who's going to take us through what we're calling the TABO project, which is the South African and Lesotho leg of the project. What we've done so far, which is really what we're calling phase 0. So we've got a lot of sort of funny terms that we're using already. And then what we have planned, which is for phases 1 and 2 coming up in the next 2 years. And then she'll hand back over to me to just think more specifically about the COVID-19 related implications. I mean, I know that I'm preaching to the choir here, but we all know that unequal gender norms predispose adolescent men and women to the risk of HIV infection, as well as unintended pregnancy. And it's very well recognized and often stated that approaches to improve sexual and reproductive health for men and women should include men. But the reality is that they're actually not often included. And even when they are included, the approaches are often not gender transformative. So gender transformative approaches are approaches that really actively challenge gender norms. They promote positions of social and political influence for women and communities, and they address power inequities between persons of different genders. Aine actually will probably get the statistic correct, so please correct me, Aine, if I get it wrong, but they recently did a gap map of interventions, and they found that only 8% of interventions use this approach with adolescent boys. So it's very much not the norm yet. And that brings us to If I Were Jack. So If I Were Jack is an intervention that has been a few years ago in the UK and run in different projects in the UK and also in Australia. And we're calling the South African Lesotho version of this If I Were TABO for now, although the name is likely to change once we actually get started with the next phase of the project. So it was developed in the UK, as I said. It's an evidence-based, user-informed educational intervention. It's targeted towards young people aged 14 or around that age, and it's designed to prevent teenage pregnancy and promote positive sexual health when it's used in the UK setting. The HIV kind of addition is something that we're adding on for our setting as well. But it's a very unique intervention because of the gender transformative approach that it uses, and it's really focused on engaging boys and young men, inviting them to think through their roles and responsibilities in preventing unintended pregnancy and in promoting positive sexual health. You can see a couple of the resources on the right-hand side there, but actually what's really also great about it is that it incorporates an interactive video drama, which is co-produced with young people in the setting where the project's being rolled out, as well as policy experts, which is kind of one of the main resources that drives the intervention. And now, as I mentioned, Anya and I have been funded by the UK OMRC starting from early next year to do further formative work on the intervention and then develop the kind of South African and Lesotho versions of the program, and then run them in a feasibility trial in both settings. So we're very excited about these next stages. But let me hand over to Anya before I steal too much of your thunder. So Anya, will you just tell me when you want me to move on to the next slide?
Thank you, Sarah. I will. Hopefully everybody can hear me, and I've unmuted myself successfully. Lovely to be here today to join you all. I'm very interested to hear all the other following presentations also. So I'm just going to give you a very quick overview of phase 0, as we're calling it, of this project, which is basically an intervention adaptation study, as Sarah has mentioned. Really central to this project was involved in project advisory groups. So we set up project advisory groups in both countries, in Kailicha, which is a township outside of Cape Town in South Africa, and also in Maseru in Lesotho. So we set up adult and adolescent and expert advisory groups in both countries, and we consulted with them centrally as part of this adaptation project. We consulted with them at the outset of the project, and then again at the end, whenever we came to sort of pull our findings together and develop plans for the next stages that Sarah talked about. And another central part of the project was conducting needs assessment. So you see in the bottom sort of arrow there under the methods. And this needs assessment involved systematic review of qualitative and quantitative literature, looking at the determinants of condom use in South Africa, well, in Southern Africa more generally. And also we conducted focus groups with young people and adults in Lesotho and South Africa. So we conducted 12 focus groups overall with a total of 77 participants. And they fed into this central part of it, which is intervention mapping exercise. I'm not going to go into a lot of detail on that today, but basically what that did was it pulled together that information, the consultation information from the advisory groups, and also the findings from our primary research and our systematic review in order to develop adaptation plans. And also to look at how we evaluate and implement this taboo intervention in this context as well. And we have plenty of theory of change models. We like a theory of change model that's basically adapted from the original. And as I said, they will then feed into the next stages. So you can move on now, Sarah, please. And we just sort of thought that something that might be of interest to you today essentially was the findings from our needs assessment, specifically from the focus groups that we did with young people and adults in both of the countries. So I'm just going to focus mostly on those today, but just to say that there is a paper currently under review which details this, the whole process that we followed in terms of the intervention mapping side of it. So Sarah and I would obviously be happy to share that with anyone if anyone's interested in it. But for now, I'm just going to focus on these key themes that come out of the focus group. So there were 4 overarching themes. First of those, probably won't surprise you, was related to unequal gender norms. And what that really was about was the whole idea. Sorry, I've got my notes somewhere now, I'm trying to find them. Sorry, so the unequal gender norms is really related to the whole idea of sexual decision making being a male privilege, if you like. And also our participants said that, carrying condoms and requesting to use condoms was still very much stigmatized for adolescent women in both countries. And also the whole notion of, male pleasure, of pleasure being a male privilege, being something that was, I suppose, that was there for men, but not necessarily for women. And a sub-theme of the overarching theme of unequal gender norms related to transactional sex. So a lot of our participants talked about the common occurrence of young women, I suppose, engaging in sexual relationships with usually older men, so that these men would provide them with money or gifts or whatever that might be. For some young women, this seemed to be a case of needing to make ends meet, or, needing lifts to school, car rides to school, and that kind of thing. And for others, it was about, gifts and receiving gifts and receiving money from these older men. So that was a key sub-theme under unequal gender norms. The second overarching theme was peer influences. And this, I suppose, was sort of interrelated to gender in a way too. And that it was about, peer pressure, but also, these restrictive masculinities, this idea that, real men don't wear condoms and that kind of thing. And there being a sense of peer pressure, especially among young men, that to use condoms somehow made them less manly in some way. And a key sub-theme under the idea of peer influence was around substance use. So a lot of our participants talked about, the substance use, alcohol, other substances was a big thing, probably as it is globally, for young people. And they talked about how, whenever substance was being misused, that was related to unprotected sex and in many cases related to sexual violence and things like that as well. So that emerged also from our findings. The third overarching theme related to access and barriers to condoms and other contraception. This was really made up of three sub-themes. The first was stigma in the community. And this was centrally around the whole idea of services for young people, sexual and reproductive health services for young people, and how young people didn't feel comfortable actually accessing those services, that they weren't youth friendly. And in the communities itself, that there was that whole idea of adolescent sexuality was stigmatized. The young people were afraid of, elders or community leaders or their parents or caregivers or whoever, finding out that they were engaging in sex because it was so stigmatized. And this applied to young women and men. Another sub-theme under access and barriers to condoms and other contraception related to the fact that, adults talking about sexual and reproductive health, talking about condom use in these contexts was culturally taboo. So young people didn't have conversations about sexual and reproductive health with their caregivers at all, basically, because it was so, some adults would see it as perverse, really having these conversations with young people. But this also then applied, of course, to other adults in the community, including teachers and health professionals also, that these conversations just often didn't happen or didn't happen enough from the perspectives of our participants. And then the third sub-theme under this access and barriers to condoms and other contraception was the misconceptions about condoms and contraceptions that still existed among the young people. These were things like, that condoms were a bad omen or contraception caused infertility, that they didn't work and things like that. So, misconceptions emerging from, I guess, a lack of education, a lack of knowledge about contraception in general. The fourth then major theme related to the determinants of condom and contraceptive use was a lack of diversion for adolescents. So a lot of young people talked about there was nothing else to do, only engage in substance use or, I suppose being out and about with their friends and engaging in substance use, and then that in itself, resulted in unprotected sex, resulted in, I suppose, risk-taking behaviour related to the substance use itself. And then, so those were the sort of four central themes and 5 sub-themes that related to these determinants of condoms and contraceptive use. But centrally, of course, then we asked the young people about the acceptability of the Jack programme. And what we found was that the young people and adults and experts were overwhelmingly positive about the Jack programme and its acceptability for use in both countries. So that was the key finding there. And then I'm not going to go into this in more detail. As I said, there's a paper available for steps 2 and 3 in terms of the developing this intervention mapping. So what that is it looks at the needs of the population, of the new population, which is the young people in Lesotho and South Africa, and compares those to the needs of the young people for which the intervention was originally developed, so young people in the UK and Ireland, and it goes through the systematic process of comparing those needs and comparing the original goals of the original intervention, the original activities and inputs, and the determinants that were targeted with the original intervention, and compares those. And also the whole, so the intervention itself, but the implementation process and how it was evaluated in the original context, and sees whether or not those are suitable for use in this new context. And really what that resulted in was minor changes to all of these things. I mean, key thing, I suppose, in terms of of the intervention itself was that this idea of these discussions being so taboo, that a component of the intervention that involves young people speaking with their parents or caregivers. So we decided, that had to be removed. While young people were happy for parents to be educated, they just did not want to engage in these conversations with their parents and caregivers. So that element was removed, just to give you an example. That was the most major thing that was changed about the intervention, I guess. And then just in terms of plans for implementation, we decided that the findings suggest that it was important in Lesotho in particular to not just conduct the research in schools, to conduct the research in schools and community settings, so that we could ensure that we capture young people that aren't in school. But before that age group in South Africa, we felt that it would be okay that we'd be able to capture, because the majority of young people at age 13 to 14, which is the target group, are still in school at that stage. Okay, Sarah, you can move on to the next slide. Thank you. So, I mean, that was a very quick findings from phase 0. And as Sarah said, now what we're doing is the start date was delayed. So that study finished up earlier this year in 2020. And then we're funded by the MRC to conduct the next stage, the UK MRC, to conduct the next stage of the study. It's being delayed because of COVID, as everything has. But phase 1 will begin in February 2021, hopefully. And it will involve sort of taking these plans that we developed during phase 0 and actually, physically developing the intervention, and then piloting that in one school, I think it's one school and one school and community group. One school in South Africa and one school and one community group in Lesotho. And sort of piloting, optimizing it then based on the findings of that pilot study. And then in October 2021, we'll move on to a cluster randomized trial in 6 schools in South Africa and 2 schools and 2 community groups in Lesotho. So fingers crossed that all goes smoothly. So that's it. What's the stop of the project itself? And I'll hand back over to Sarah now to consider the implications of COVID for the project.
Thanks. Can you hear me? Yeah. I mean, obviously there will be a number of, well, there have already been, there will continue to be implications for the actual project and how we will run our intervention development workshops and various, even data collection, etc. in future. But I actually, I've sort of been thinking a little bit more broadly about the situation that we find ourselves in and the kind of usefulness of this project moving forward in this new normal. And I just wanted to reflect on that a little bit before we close. So I think we're basically out of time. But basically, I think we've seen that innovative intervention methods are needed. So this is a new world. There's different things happening. Service delivery for adolescents has been very disrupted by COVID. Even when adolescents can access services, there's quite a lot of stress in the healthcare system. And resources within the system will have often been diverted away from adolescent health issues. There are also adolescents in both of these sites who may have fear of accessing healthcare systems even when they are functioning. And so, that plus the fact that generally speaking, we've always relied very heavily on schools as a means to access people, means that there's been quite a shake-up in terms of what kind of delivery models are going to work in future, since we can't rely necessarily on schools anymore. So that's just one thing that I think it'll be interesting to think about with our project as we move forward and think about delivery methods. The other is that we obviously have seen that the COVID pandemic's had an enormous impact on women, and there's been quite an unequal impact in terms of loss of employment and school dropout and other indicators. So it's really highlighted for me the importance of gender responsive programming within sexual and reproductive health, but also in other fields as well. And then last of all,
we have to stop you. Sorry about that, if that's okay. I'm sure we can take around implication towards the end, if that's all right. I'm going to go ahead and introduce our second speaker, Kathryn Roberts, who will be speaking about adolescent fatherhood, insights from an existing data and potential impacts of COVID-19. Over to you, Kathryn.
Hi all, thanks for having me today. I'll just upload my screen and let me know if you can see this in full there. Excellent. So to kind of follow on from the previous presentation focusing on pregnancy prevention among male adolescents, we're going to take a slight shift to look at what insights we can draw from the existing data within the Accelerate Hub regarding adolescent fatherhood and the potential experience of adolescent fathers. So just to give an outline for the presentation, I'll quickly give some background and an overview of data sources before diving into some preliminary data. And then finally, I'll round up with an overview of some considerations relating to the current pandemic and what this might mean for adolescent fathers. So what do we know about adolescent pregnancy? We know that sub-Saharan Africa has some of the highest adolescent pregnancy rates in the world, and that these rates are likely to climb over the coming decades. Current estimates predict that 1 in 5, so 20% of female adolescents within the region experience pregnancy between 10 to 19 years of age, and it's this WHO definition that will be utilised within the results presented today. We know that in attempts to address the challenge of adolescent pregnancy, the majority of research and programming responses focus on adolescent motherhood and pregnancy prevention. And as a result, adolescent fathers are often neglected from the literature and within the development of policy. And in the context of the data that I'm going to present today, there remains limited data from South Africa concerning adolescent fathers. We know that adolescent pregnancies may result from age-disparate sexual relationships. However, adolescents are also becoming fathers, and like their female counterparts, adolescent fathers also have to navigate the experience of adolescence while adjusting to fatherhood. And so in order to develop appropriate support systems, an understanding of their experience is required. And as kind of Sarah and Aine mentioned, and as with adolescent motherhood, the experience of adolescent fathers is impacted by numerous contextual factors, such as some of these here on the right, which remain key within the interpretation of results of research findings and within programmatic responses. So it's worth bearing these in mind as we move forward. So the data I'm going to be presenting today is drawn from 2 studies undertaken by the Universities of Oxford and Cape Town. The first is the Mzansi-Wako Adolescent HIV study, which I'm sure many of you know is a longitudinal prospective cohort study of over 1,000 adolescents living with HIV and a comparison group of almost 500. And participants were recruited from public health facilities and followed up over 3 waves. Amongst a multitude of health and wellbeing questionnaires, male participants were also asked whether they had made somebody pregnant and had fathered a child. And the data presented today from this study will focus on 566 male adolescents drawn from the most recent wave of data collection. I'm also going to present data from a second study, which is the Hey Baby study, which is a sister study of the adolescent HIV study and supplemented the study data with over 1,000 adolescent mothers and their children. And the aim of the study was to understand the experience of adolescent parent families within South Africa. In addition to data relating to, again, health and well-being, parenting, and child development, adolescent mothers also reported on the fathers of their children, inclusive of their age. And we have preliminary data relating to 957 fathers of children born to adolescent mothers, as well as numerous other measures reported by the adolescent mothers themselves. So we'll be looking at these proxy measures as we go forward. So utilising the adolescent HIV study data, we asked a few questions. What is the prevalence of adolescent fatherhood in the sample? Who are adolescent fathers in the sample, and do they differ comparative to non-fathers? So the percentage of adolescents reporting fatherhood in the sample was 1.4%. For reference, as you can see in the graph on the left, this is notably different to the proportion of female adolescents reporting a pregnancy within the same sample, and the proportion of adolescent pregnancy reported in the sub-Saharan African region, which we spoke about earlier. So adolescent fatherhood is seemingly uncommon, and this may be underreporting due to a number of factors, such as unknown pregnancies, paternity uncertainty, cultural factors such as lobola payments, which translates into bride price, or not wanting to admit fatherhood. These are super small numbers, and therefore any results are only indicative, but hopefully they do give us some insight into the experience of these fathers. So the average age of adolescent fathers at the time of pregnancy in the sample was 17.5 years. And despite small numbers of adolescent fathers within the sample, adolescent fathers were likely to be older at the time of the study comparative to non-fathers, and were less likely to report living with HIV. No differences were identified relating to dwelling location, housing, or mode of HIV infection. If we look at mental health, again, these are super small numbers and we're underpowered to look at differences. So these data are purely indicative, but there is potentially a higher prevalence of depressive and suicidality symptomology among adolescent fathers comparative to non-fathers within the sample. Further exploration is needed, but the mental health and well-being of adolescent fathers should remain a consideration. Now moving on to the Hey Baby data. So here we have adolescent mothers reporting on the fathers of their children. 16% of fathers were adolescents at the time of the study, as reported by the adolescent mother. The average age of fathers at the time of the birth of their child was 20 years of age, and this ranged from 13 years of age to 40 years of age. And just over 50% of fathers were adolescents at the time of the birth of their child. And it's this group that we will explore comparative to older fathers at the time of the birth of the child over the coming slides to begin to answer a few queries relating to fathers' relationships with adolescent mothers and their involvement within pregnancy and parenting. So first, to look at the relationship of fathers with the adolescent mother. So within the total sample, 46% were still in a relationship with the mother, and this did not differ between those who were between adolescent and non-adolescent fathers. The majority of mothers knew where the fathers of their children lived, and again, this did not differ according to age. Adolescent mothers were less likely to know the HIV status of adolescent fathers comparative to non-adolescent fathers, and very few fathers did not know about the birth of their child. And again, this didn't differ between groups. When focusing on pregnancy and the pregnancy period, very few fathers attended the first hospital appointment, and this did not differ between groups. About 20% were happy and supportive of the pregnancy in the total sample, and adolescent fathers were found to be less likely to be happy and supportive, as reported by the adolescent mother. Adolescent mothers were less likely to argue about money with adolescent fathers comparative to older fathers, possibly due to adolescent fathers' access to financial resources. And continuing with some of the variables looking at money and maintenance, very few adolescent mothers sought maintenance from fathers. And again, this didn't differ according to age of the father. Approximately a fifth of fathers made a payment to the mother's family. So for instance, lobola payments, which we spoke about earlier. And just for context, relating to this variable, approximately 50% of families did not ask for such payments to be made. And again, this did not differ according to age of the father. Jumping on to focus on the involvement of fathers with their children, very few fathers lived with their child, and unsurprisingly, this was lower among adolescent fathers. Very few fathers were the main caregiver of the child, and this did not differ according to age. Father engagement with the child, so for instance, looking after the child, buying things, spending time with their child, was overall quite low. And again, this did not differ between groups. When we look at the development of children, so we have the Mullen scales of early development within the study, and we find that the children of adolescent mothers are doing okay. And there's a trend for children of adolescent fathers performing slightly better, although this finding needs further exploration, and the promotion of father-child relationships may further enhance such findings. So despite the limitations of this data, collectively, these two sources of data presented today allow us to begin to build a narrative relating to the experience of adolescent fatherhood, which in time can hopefully help to inform programming and future research directives to be able to promote positive outcomes for adolescent parent families. But the world has changed since this data was collected. COVID has had impacts on all aspects of our lives, and this brings about a number of considerations relating to the potential experience of adolescent fathers at this time and future research relating to adolescent fathers as well. So within this slide, I've picked a few examples of some of the impacts of COVID and speculated based on emerging literature and responses about some of the potential impacts for adolescent fathers. This is in no way a comprehensive list, but it hopefully gives us a starting point when we start to think about this group. So firstly, lockdowns. Lockdowns may lead to an increase in adolescent pregnancy, kind of bored at home. And they may also lead to an increase in alienation and isolation. And we need to consider what that may mean for access to children. And is this a further barrier for adolescent fathers engaging with their children? There may be an increase in poor mental health. We've seen this may be of a concern for adolescent fathers, but as a counter argument, and based on kind of some of the results that Mark Orkin presented in a previous webinar, some groups are actually doing better than anticipated during lockdown, and therefore mental health may not be as bad as we think. Lockdowns may also lead to an increase in poverty and access to financial resources, which may be a barrier for father involvement with their children. When we move on to health service disruption, a lack of reproductive health services, again, may lead to an increase in adolescent pregnancy. Disruptions to antenatal and postnatal care may mean that those few fathers that did attend hospital appointments are now no longer able to do so. When we think about school closures, again, this may lead to an increase in adolescent pregnancy, and there's considerations there regarding the retention of adolescents, including both adolescent mothers and fathers within schooling. And then when we look at research disruption, there's obvious challenges in follow-up data, something that we're all trying to mitigate against, and has been a common thread within these webinars, but also sampling challenges as well. So often the recruitment of adolescent fathers is hindered by a lack of services for this group, and further reductions in such services may mean that adolescent fathers become more inaccessible. So some food for thought there, which I'll leave you with. Just a quick thank you to our funders, the study teams, and as always, our participants as well. Thank you.
Thank you so much, Kathryn, for that insight into fatherhood from the perspective of the males and the females. We'll move on to our next speaker, Rachel Yates, who will present on child marriage in the time of COVID-19, stories from the front line. Over to you, Rachel.
Great, thanks very much for the introduction and the opportunity to join again. I'm just looking for my slides, which seem to have disappeared off my screen. I'm just wondering whether you might be able to share those, Diana.
Sure, will do.
But maybe just to, so this is going to be a joint presentation between myself and my colleague, Yvette Muhia in Kenya. And we're both working with Girls Not Brides, which is a global partnership working to address child marriage. Apologies for the slides disappearing. They were there a minute ago, but I don't know what's happened to them. What we'd like to cover today, if we can move on to the next slide, is really just to give a very brief introduction to Girls Not Brides, to talk a bit about the impacts that we're anticipating that COVID-19 will be having on child marriage, to draw out some of the lessons that we're hearing from our members across Africa, and to focus in on a few policy recommendations with a focus on the education sector. So next slide. So just to start with, a very brief word about Girls Not Brides. We're a membership organisation. We have about 1,500 members, 58% of which are working across Africa. And our role as a secretariat is really to be providing a central support and coordination body across the partnership, to support the partnership as a representative of an advocate on child marriage at different levels, at a global, regional and national level, and also to act as an expert resource on child marriage within the global movement. So a lot of the work that I'm doing in the learning department is really about supporting the synthesis of evidence, the uptake of evidence and peer learning. And I should also mention that the majority of Girls Not Brides members are sort of fairly small community-based organisations. Next slide. So not to be outdone by previous speakers, we also have a nice theory of change, and it's probably a model that's very familiar to you. I won't go through it in detail, but really looking at an ecological approach to change, which looks at both interventions at the level of the girl, at the families and communities, and at the broader enabling environment in terms of services, laws and policies. And we're in the process of updating this at the moment, but it's actually sort of proving, we're actually looking at it now to see how we can update it in the context of COVID and think about how COVID has affected the degree of interventions needed across these different sectors. Next slide. One of the roles of Girls Not Brides in terms of our sort of knowledge uptake function, we've recently started a collaboration with UNFPA and UNICEF to support a better coordinated and harmonised research agenda on child marriage, having identified a number of priority research gaps. So I just wanted to flag this because I think there's a very good opportunity for potential linkages with the Accelerate Hub to ensure that the Hub's research is reflected here, but also that some of the Crank's research feeds back into the Hub. Next slide. So looking at the impact of COVID on child marriage, next slide. We have a number of studies that have come out this year which have been looking at the potential impacts, and sort of a number of models have been developed. The one that we think is potentially the most reliable is the UNFPA estimate that anticipates potentially an additional 13 million additional child marriages as an impact impacted by COVID. And this is down to services for adolescent girls, particularly around education, protection, and so on, which is estimated could reduce the number of child marriages averted by 7.4 million. But on top of that, the increasing impact of COVID on poverty, which is likely to increase the number of child marriages, and they predict by an additional 5.5 million approximately. We're also seeing other estimates coming from organisations like Save the Children, anticipating another 500,000 girls a year marrying due to COVID. One of the things that we would like to see done better is better coordination of some of these estimates, because sometimes they're confusing for advocacy purposes. And this is something that we're hoping that the Crank can help in terms of this harmonisation. Next slide. So we've also been looking at the potential pathways through which COVID can impact on child marriage. And the sort of main drivers we see is partly COVID impacting on the education sector with school dropouts. And there's quite a lot that's been learned from previous shutdowns, for example, during the Ebola crisis, which led to a 65% increase in teenage pregnancy. There's a real concern that even when schools do reopen because of increased poverty or the fact that girls and their families have lost a lot of learning time, there may be unwillingness to return to school. Also, we're hearing a lot about disruption to sexual and reproductive health services and the risk that that creates for early and unwanted pregnancies. And also the risk of girls being sort of forced into sex and not having the protective services around them. The increased sort of risk of violence and abuse against girls. In some contexts, we're seeing maybe a reason why parents want to marry off girls earlier as a protective strategy. And we see that quite a lot in other situations where there is often more sort of instability and less supervision of adolescent girls. And then finally, the massive economic impacts, which we're really only starting to see the real impacts now, which are impacting on transactional sex, the cuts in expenditure on basic services. And this is likely to have a massive impetus for child marriage, both from the perspective of the individual, but also from the family. So as we've been looking at some of these drivers, we have been also developing a couple of resources which might be useful for the group. I don't know if you can move on to the next slide, Deanna. So one of the resources is looking at COVID and child marriage and an agenda for action. So really trying to bring some of the evidence that we're seeing, that we're hearing from members into an advocacy brief. And this is also complemented by a separate brief we came out with this year looking at child marriage in humanitarian contexts, which really, I think some of the similar themes about the importance of supporting girls and families' resilience to withstand sort of crises, whether it's sort of more protracted like we're seeing now or more emergency acute crisis. More about what we're hearing from our members. Next slide.
Thank you, Rachel, and hello, everyone. I want to start off by highlighting with a broad brush some of the trends that we noticed within Africa before COVID. And we began to see some reductions in prevalence at sub-Saharan level, but also at the sub-regional level. In East and Southern Africa, for example, we noted that there was decrease in prevalence between 2018 and 2020 with 31%. West and Central Africa, we noted a decrease in prevalence to 39%. However, we did want to note that there's now distinction between the decrease that we are seeing in East and Southern Africa and the decrease in West and Central Africa, which then prioritizes most of our engagement in the Francophone region. We are also worried that if we begin to have such a plateau, by 2030, we'll be increasingly seeing high cases of prevalence in West and Central Africa. Next slide, Anna. So, as mentioned, we are not a research-driven institution, though we do consolidate research that has been conducted by our partners to disseminate to our members. For example, Gauge by ODI have been able to highlight excellent research in Ethiopia, particularly in the Amhara and Afar region, where we've seen an increase in COVID-19 during COVID times, an increase in child marriages during COVID times. And because this has been associated with the lockdowns, associated with traditional practices, social norms, with schools being closed, we are seeing that this has become an alternative for some families to marry off their children. We also recognize the relationship between child marriage and other sectors, as has been highlighted by Rachel. So if you're looking at health, Across Ethiopia, there's been access to contraception, which has been reduced. Therefore, unmarried girls are likely to fall pregnant and therefore get married because of a result of teenage pregnancies, linking to the conversations we've had in previous discussions. Then because girls are not going to school, they're at risk. Boys also are at risk, those who have been attending secondary education. And a quote also that has been highlighted from a boy, adolescent boy, so adolescent perceived might be an adolescent father in the future. He says he's going to marry a girl aged 13 who has been temporarily dropped from grade 3 due to school closure because of COVID. They anticipate that their wedding will be held after 10 days and are making preparations, just like any other couple would, for HIV testing, bridal gifts, and food preparations. We've also seen increased cases of FGM in countries such as Kenya because of the lockdowns associated with COVID-19. Next slide. One of our members, Plan International, undertook this research that was recently shared, Under Siege, the impact of COVID-19 on girls in Africa. And one of the quotes from Mozambique says, things have become very uncomfortable for me since the state of emergency began. Being at home all day with my family is dreadful because they are rushing me to get married. So societal pressure, family pressure for girls who are in school, retained in school, now not because of COVID, have resulted to child marriage. Also understanding the economic hardships that have been reflected for these communities, linking the children to get married as alternatives. Next slide. So some of the results that came out of this research, we recognize that more than 2/3 of the African countries introduced distance learning, but only 15 countries have offered it in more than one language. So already we are seeing increased inequalities on the basis of language across Africa. We are also looking at increased inequalities around digitalization. So 37% of girls in Uganda with no access to TV and radio-based material, yet the Ministry of Education is running programs on TV and on radio. In Ethiopia, 2% of rural households have access to TV, therefore excluding majority of learners from TV-based learning. We are also seeing increased inequalities or exacerbated inequalities in the rural-urban and gender-digital divide, where girls are more affected than boys and rural girls more affected than urban girls. So we can't look at this situation as an homogeneous problem. Similarly, social and gender norms in rural areas often dictate that education resources are directed to boys, because then this is seen as more beneficial than educating girls, which of course will exclude the girls. COVID-19 has also exacerbated existing vulnerabilities when we look at the intersections between or intersectionality between access, ability, where we're looking at girls with disabilities not accessing education, and disabilities or inabilities could be broadened, the range of which could be broadened beyond physical inability. Next slide. So what have some of our members told us? Anecdotal evidence that we've received from our members through our conversations with them. One is we need to raise voices of and protect girls who are increasingly at risk. And one of the ways that our members have been adapting is using social media. So reaching out to the girls where lockdowns have been instituted through technology like Twitter, WhatsApp groups, facilitating smaller girls clubs. So previously we would have girls clubs of maybe 50 people meeting. Now you have smaller groups of 5 to 10. And very crucial is the use of helplines, which have been a partnership between government and civil society to record cases of child marriage. We've also heard that online and offline learning has really been an opportunity in the face of COVID and in the face of school closures. So the opportunity that has been presented here is that government and partners have worked together to mitigate that digital divide that I mentioned earlier, so that we can get access to communities where digital learning is not possible. However, there have been challenges with civil society space shrinking in some countries. Initially, when we had the pandemic onset, we had cases of violence being committed by the state to the citizens in countries like Nigeria and in my own country, Kenya. And therefore, we see a risk of rollback on the progress and gains that have already been made in terms of partnership with governments. However, some governments, on the other hand, are using this opportunity to work with civil society because they recognize the civil society reach within the grassroots and community spaces. In terms of budgets, we know that these, particularly for education, are at risk. There are competing priorities right now. We understand that with the context of nationalism that is happening, monies are reducing, dwindling resources. So what happens when it comes to balancing this for gender responsive education and social protection? Next slide.
Thanks, Yvette. Sorry, we're out of time, but thank you so much for that. Unless you want to just end off there. Our next speaker, Rachel, did you have any last words for us?
No, I think we can talk about the advocacy recommendations maybe in the question and answer at the end. Okay,
lovely. Thank you very much. Fascinating. So our next speaker I'm really pleased to introduce is Dr. Kate Orkin from Oxford University, who's going to talk to us about emergency social protection in response to COVID-19, options for developing countries. And I'm sure much of what you've just heard from Yvette and Rachel will resonate in the ideas and words that Kate's going to cover for us. Thank you, Kate.
Can you see that screen?
Absolutely, lovely.
Okay, great. So this is a sort of policy review article rather than an academic piece, and it's just going to take a slightly different theme from the stuff that's been presented so far. And that's, I think, it's really important because social protection has been one of the areas of policy that's been at the forefront of countries' responses to the COVID pandemic. This piece basically, the context everyone is very familiar with. Many countries have put in place very strict public health responses. And there's been an enormous economic shock in many countries. And so in many cases, governments have very quickly adopted emergency economic measures to provide households with some sort of social safety net. And in many cases, the emergency actions that countries took during the COVID pandemic have actually spurred development of longer term social safety nets. So what this paper tried to do was, so I work a lot on social protection initiatives in Southern Africa, and then my co-authors, so Francois Gerard works a lot on Latin America, and Clément Imbert on South Asia. And so what we wanted to do, we wrote the first version of this piece in April. So it's an article that's appeared in the Oxford Review of Economic Policy. I think Diana has circulated this already. But we wanted to try and give a broad overview across many different countries of what countries had done, and also what was possible to do in response to the pandemic. The piece is, obviously that started in April, and it's actually been very exciting to see how many of the sort of recommendations or options that we put forward have been implemented in many countries. But basically our main argument was that it would, many poor countries looked initially at the responses that rich countries had to lockdowns, extensive furlough schemes, large cash transfers that were emailed out to households in the US, that were mailed out to households in the US, loads of really big interventions in developed countries. And there was a bit of worry among many development practitioners of, what is the developing world going to be able to do? They have as extensive an economic shock, but is it going to be possible to respond in the same way? And, obviously, these countries are much poorer, so the magnitude of the response has not been as big. But what we argued and what has actually happened is, it's become very clear that middle and lower income countries actually are able to put in place remarkably extensive social safety nets and cover a large portion of the people in their populations. But they need to use a bit of a broader patchwork of different kinds of solutions than are used by higher income countries. And so, there've been three broad ways in which countries have responded. So many countries have expanded their social insurance systems. So those are contributory systems, mainly people who work put in sort of pension savings or other savings so that they can be covered when they become unemployed. And that has been the bulk of response in developed countries. However, in lower and middle income countries, most of the responses ended up being through social assistance programs. So these are non-contributory. These are sort of programs that go to people just by virtue of them being in a particular age group or having a particular vulnerability, rather than because they pay into the system. And so, although the response has been slightly different, in developing countries, it's been more through social assistance. In developed countries, it's been more through social insurance. Actually, there have been ways in which low and middle income governments have been able to reach the majority of their citizens with some sort of social safety net payment. So we identified, those different ways of reaching citizens. And then the final point that we made is that it is possible to reach many of the hardest to reach by involving local government and non-state institutions to reach people who might not be covered by these other systems. So I'm going to, this is just a kind of overview of the article. So I'm going to give you a bit of an introduction about the key features of developing country economies that meant people were quite worried about how social protection would it be able to expand, but also some of the strengths that have meant that actually expansions could be done. I'm not going to talk a lot about social insurance because it hasn't been the widest used response, partly because many people are not formally employed in these countries. But I'll focus on the ways in which developing countries have responded through social assistance and sort of filling in the gaps through local government and non-state institutions. So I think the developing countries, when the pandemic hit and they needed some sort of social safety net response, faced some challenges and some opportunities. On the one hand, there were a lot of challenges. So households were very poorer, were much poorer in these countries. They had limited access to credit and savings, but also it was very difficult for them to respond, in particular, to a shock. So a lot of the time, households are supported through a social network. So richer people in the cities will transfer money to rural areas when there's a big economic shock. But everybody was affected by COVID, and that meant that the sort of normal ways that households had to protect themselves were not there as much. And everyone was very worried because a lot of the way that developed countries responded was through social insurance systems. So in particular, paying for workers, the state paying the wages of workers who couldn't work. That was really difficult to do in poor countries because many workers were in informal sector jobs or were self-employed. And then others, the welfare system is also more limited in those countries. So there were a lot of challenges to getting economic support out to people during the lockdown. There were also quite a lot of opportunities, and developing countries really have taken advantage of these. One is that there's often very strong networks of local government and non-state actors who are able to reach harder to reach portions of the population. And then there's actually, it turns out, developing countries over the past 20 years have built pretty extensive social assistance programs, and those have been built on to reach many households with emergency assistance. And I'll talk a bit about how that's happened. So in the paper, we go over a little bit, basically this argument saying it's going to be really tricky to do social insurance because many, you see Africa here. There's very few countries that have any unemployment insurance type system, so it's quite difficult to use those. But on the other hand, there is quite a big portion of the population covered with social assistance programs, and you can see there the sort of different types of programs that are involved there. So as we said, it was going to be much easier to work through the social assistance rather than the social insurance system. So I'm not going to talk a lot about the social insurance system, but different developing countries have used some of the same schemes that were used a lot in richer countries. So job retention schemes, subsidizing, if workers were let go, requiring mandatory severance payments, and then in some cases providing some assistance to the self-employed. But this hasn't been where developing countries have done the bulk of their response. The main thing they've done has been building on existing social assistance programs. So these are things like cash transfers, in-kind assistance or subsidized access to essential goods and services. And these are really good because they, they reach a very broad set of people, because by nature, they tend to either be means targeted or be universal. So they're not only restricted to people who happen to have been employed, they cover a much broader range of the population. And so countries had to make pretty big decisions about which kinds of programs they invested in. What's tended to happen across countries was that in cases where households were able to buy goods and services at reasonable prices, then countries have tended to do cash transfers. In cases where, and there were very few of these, where it was difficult to actually procure food or prices had gone up a lot, then countries tended to do a little bit more in-kind provision, so provision of food parcels. But there's always a tension between what's going to be best in each circumstance, and that's broadly how countries chose what to invest in. But we just mapped out a range of different country examples, but countries have done a wide range of these sorts of strategies to expand social assistance. So one thing that they've done is taken existing programs and made them temporarily more generous. So there's an existing pool of people who, for example, receive a cash transfer. And so countries had a list of beneficiaries, they had an infrastructure. And so many chose to temporarily top up the amount received by the current beneficiaries during the pandemic. They've also sometimes made programs that have conditionality, like you're required to work in a public works project in order to get a grant. They've sometimes made those programs unconditional, or the government has allowed people to delay payment of bills or further subsidized payments of utilities for people. So a lot of the extension of social assistance to deal with the pandemic shock has actually just been expanding what was offered to existing program beneficiaries. But another really interesting thing that's happened is many programs have been temporarily extended to new households extremely quickly. And this has been really exciting for social protection practitioners, because it's shown that really the issue was one of sort of political will, rather than it being too difficult for poor countries to set up infrastructure that reach these people. So two of the ways that countries have been able to expand programs really quickly, the one is in many Latin American countries, in order to target conditional cash transfer programs, they will collect a census of the poor, so of all people who live in particular poor areas. Often the countries will target the very poorest of that group, but during the pandemic, they were able to use those lists to just increase the portion of poor people who were covered by a cash transfer program. So that was how Peru and Brazil have added, 3-5 million people into their beneficiary group in a couple of months, which is quite remarkable. The other is that many countries have set up systems where they have a national identity document system, and that's linked to a very basic bank account. And if they had those systems in place, they were able to use those to pay transfers out. So that's what Chile and India did. So you can see there that countries were able to make really quite remarkable extensions of programs very quickly, but that did rely on having some basic infrastructure in place. Just in the last minute, so this was, to give different examples of some of the, so Kenya and Indonesia, for example, topped up their cash transfers. Indonesia increased the amount of subsidies. India did big in-kind top-ups. So you can see different examples of what countries did. And then the final thing countries did was, involving local governments and non-state institutions when it was difficult to, for some populations that were harder to reach. And so in some instances, they worked through local government that has the strength that they already have a lot of funding or staff in place at local level. They also may have better information on local needs and preferences and potentially be more easily accountable to communities. And then, there's also a lot of non-state institutions. So we picked up, for example, community organized savings groups, savings and loan associations, burial associations, professional organizations and residents associations. And actually, it's been remarkable to see how many of these sorts of associations have been used by governments, but have also, raised money and provided relief themselves. And yeah, so we go through a number of examples of this in the paper. So Kenya had in the past used these savings and loan associations to enroll participants into its national health insurance scheme. But even India had used many of these rural livelihood missions and self-help groups to enroll people into development programs. But as the pandemic has rolled on, these sorts of institutions have often been used to provide relief efforts. So I'll just conclude basically by going back to the intro. So the main way in which developing countries have responded has been, rather than through social insurance, through existing social assistance and then local government programs. But if you'd like to look at any of the specific country examples, you can refer to the paper.
Thank you so much, Kate, for that presentation and really highlighting the current resources countries within Sub-Saharan Africa are using to support us during this COVID-19 pandemic. We're going to move on to the next presentation by Dr. Rita Tamambang from the University of College Hospital in Nigeria. And she'll be presenting on the perspective of Nigerian youth with lived experiences of severe mental illness on the psychological impact of the COVID-19 pandemic. Over to you, Dr. Rita.
Hello.
Hi, we can hear you very well.
All right, so good afternoon, everyone. So I'm going to put my video off so I can maximize my bandwidth because the internet connection in this part of the world has been very epileptic. So I'm going to be talking on the perspectives of Nigerian youth with lived experience of mental illness on the psychosocial impact of the COVID-19 pandemic. So as a matter of introduction, the data used for this presentation is collected as part of an ongoing internationally funded research being carried out here at the Center for Child and Adolescent Mental Health at the University of Ibadan in Nigeria. The project is actually aimed at working directly with persons with psychosocial disabilities to design packages for care and support. And it's actually in accordance with the Nothing About Us Without Us. So we try to incorporate people with psychosocial disabilities into the research. So I will start with showing you the trend of events of COVID-19 in Nigeria. So COVID started, the first case of COVID was recorded in Nigeria around mid-March. And as we see, there was a steady rise with a plateau around July. And then it went down started going down around August, and it's presently at this level. So around April, we had public health measures that were instituted by the government. We had closure of businesses, closure of schools, and curfews. And one important thing to note here is that in Nigeria, majority of the population belongs to the informal economy. And so their livelihood was greatly impacted because their daily activities or their livelihood involved face-to-face contact with the public. So these measures really had a lot of impact on the population as regards closure of businesses. So around the plateau, around July, schools were closed. We had curfews in place in areas like Abuja and Lagos, where there was really high prevalence rates. As you can see on this picture, this is one of the most populous cities in Abuja. We see a policeman sitting and trying to control or to put in order as regards the curfew that was instituted. There's actually nobody on the road. And then we see children here trying to learn via the radio and doing distance learning. And also, as concerns the mental health services, here in Ibadan at the University College Hospital where the study was carried out, we had closure of wards and outpatient clinics. We had to close them down. And then we were conducting consultations via phone. We were doing teleconsultations, and we only attended to emergency services. I got this from the UNICEF website. UNICEF asked some Nigerian children to sketch out their feelings about the COVID-19 pandemic. And this is what one child drew. He drew this 3 chicken caged in a cage. And the child said, the 3 chicken represents my family, the cage represents the lockdown ordered by the government, and the corn represents food, opportunities, and knowledge. I painted the chicken comb red because red signifies energy. I realized that my parents' energy now is useless. And if this continues, we will end up not eating. So this is what a child had to say concerning the pandemic or the lockdown and its measures. So people with psychosocial disabilities are frequently left behind with less access to health, education, and other facilities, even in times of where we don't have emergencies. And this is actually worse when in times of emergencies and such as the ongoing COVID-19 pandemic. Their access to affordable medications is usually reduced, as well as hospital services. Preliminary reports from high-income countries suggest that people with psychosocial disabilities may be particularly vulnerable in this current COVID-19 pandemic. Reason why we decided to conduct this study in Nigeria, because we had little or no knowledge about how has the pandemic impacted people with psychosocial disabilities. So the aim of the study is to explore the impact of COVID-19 pandemic on the physical, psychosocial, and social functioning of young people with severe mental illness in Ibadan, Nigeria. And the objectives, there were actually 6 objectives, but for the purpose of this presentation, we have reduced it to 4. The first objective is to assess the understanding and perception of young people with psychosocial disabilities about COVID-19. The second was to explore how the mental health of young people with psychosocial disabilities have been transformed during the pandemic. And the third was to also look at how their existing support structures have been affected during the pandemic period. And then finally, we'll talk about or identify coping mechanisms they've used to mitigate the impacts of the COVID-19 on their lives. So actually, this is what I'm presenting is going to be a preliminary result because we are still in the point of data collection. We've been able to collect conduct about 12 interviews, which I will present results for 10. So the study location was the Child and Adolescent Psychiatric Clinic of the University College Hospital, Ibadan. It's a cross-sectional qualitative study that targeted young people between the ages of 18 to 25 years who have been diagnosed with severe mental illness, such as schizophrenia or bipolar affective disorder. The sample size was estimated at 20 in order to attain saturation. We used the following instrument, the socio-demographic questionnaire that collected information on age, gender, level of education. And then we also had a key informant interview guide that was developed with a peer researcher, who is having a psychosocial disability, and in conjunction with other team members. This was to give us an insight, or to make the questionnaire rich, and to give us an insight of what these people might be going through. And it was also it was a structured and open-ended question that we asked to each of the patients, and consisted questions on all of the objectives which I've mentioned before. So for the study procedure, we randomly selected patients from a pool of patients, and then we did face-to-face in-depth interviews with preventive measures such as wearing of face masks and social distancing. And then we went further to do a manual coding and did transcriptions, and then did manual coding to select emerging themes from the transcriptions. So as concerns the preliminary results, as at the time when I prepared this presentation, we had conducted 10 interviews. The age range was 18 to 24 years, and we had equal distribution of the gender. 50% were female and 50% were male. Majority of the participants had a tertiary level of education, with most of them being in the university. So as concerns the perception and knowledge about COVID-19, some participants said the themes that emerged were it's a disease emanating from China. Some people said it's a pandemic spreading all around the world. Some said it's a deadly disease, and others said it's a disease that needs public health measures such as lockdown. And for an example of the quotes, I will pick one. This participant said, COVID-19 is a virus that COVID-19 is a virus. The current pandemic, it's currently affecting the whole world and has actually drawn the whole world into some kind of stress. As concerns the second question, it involved the reactions. What was the news, or what was the reaction of people with psychosocial disability to the news of COVID-19? And the themes that emerged were, some said they were scared when they first heard the news, some said they were anxious, and interestingly, some said initially they were very happy. So I will pick on initially very happy. One of the participants said, at the instance, I was very happy. Not that I am wicked, but I have been in school for like 6 months, reading, waking up at night. So that gave me a well-deserved break. And we also went further to inquire about what are the local names that is attributed to COVID-19 in the community. Some people said they call it Chinese virus. Some people said it is called Corolla, as in Toyota Corolla, and some people said Coro. And we also looked at the mental health and life impact of coronavirus. The themes that emerged were, some people said they had an increase in mental health symptoms, such as sadness, suicide, and some others had also had relapse of mental illness or had a feeling of relapse. One of the quotes was, during the lockdown, I was lazy, I woke up late, lost interest in eating, which are all symptoms of depression. I was actually suicidal. The way I perceived myself then, my self-esteem was nothing to write home about. Another theme that emerged was increase in negative emotions, such as frustrations of being delayed in academics, fear of contracting the virus, and losing academic interest and passion. I'll also give an example of one of the quotes. One of the participants said, during that period, I saw myself like a failure, and it was frustrating because no matter how hard I tried to develop myself, there seemed to be no change. However, there were also some positive remarks with respect to the life impact of the coronavirus or the lockdown. Some said it was time for recovery and self-discovery. Some said they had time. It was a time for new opportunities. They could volunteer and start up a new business. An example of one of the quotes, personally, the COVID-19 pandemic has to some extent helped me because I had some personal time to myself, whereby I did some reasoning on my own. Still on a positive side, another theme that emerged was building relationships with family and making new friends. And an example of a quote is, it was good experiencing motherly care once more because I have missed that. Since I got admission into the university, I only go home once a year. But during the lockdown, I stayed home for 6 months with my mom. I enjoyed every bit of her care. I enjoyed the stories she tells, the way she prays. In fact, I'm missing her already. The coping strategies that some of these patients employed were reading of motivational books and watching films, speaking to mental health counselors, family and friends. I'll just pick out one of the quotes. One of the participants had this to say, I used to play a lot with my junior sister. She tries to carry me and all. Then my mom is a very jovial person. She really plays. So we all try to play together. And sometimes when the lockdown was eased, we used to go to the mall and we just go there to buy food and eat ice cream. Another coping mechanism was praying and reading the Bible, engaging in hobbies, singing, reading, listening to music. I'll pick one of the quotes too. One participant said, I had to read my Bible more, and there's no way you read your Bible and you wouldn't have seen something you did wrong. So I had to pray and ask God for forgiveness, sing, and this impacted my life positively. Still on the coping mechanisms, interestingly, some people engaged. There was an increased use of social media platforms. Some of the participants said, I will log on to Facebook and read people's posts, chat with my friends, and make new ones. For the impact on support structures, Many of the participants said there was no change, or actually there was an increase in the emotional and physical support and assistance they got from the family. And one of the quotes, "I think the support I received from my family has increased during this period because we can talk more. My sister helps me a lot in washing the plates, and Momsi also tries her best to help me because I am the last born." And finally, on the impact on support structures, there was actually decreased financial assistance from family, as shown by one of the quotes. My parents couldn't send me money because they didn't have at the particular time when I needed it. So I could not get money from my jobs, so I had to call my friends. So in conclusion, the study reveals that there was a lot of positive effects as regards the impact of COVID-19 pandemic on youths living with psychosocial disabilities in Africa, probably because of lower prevalence in most African countries. And the study also brought out the role of the immediate family as a support structure for people with mental health problems. But however, the COVID pandemic and its resultant lockdown has had some negative consequences, as we saw in the presentation. It precipitated feelings of fear, anxiety, and panic, and also relapse of mental health conditions. So there is therefore need for health policies and restructuring to ensure continuous provision of health services and medications to this group of people. And to wrap up, I would like to acknowledge the team members, Mrs. Olayinka Aturu, who is a peer researcher. She actually did a lot of help in coming up with the questionnaire. Mrs. Adiola Afiliayon and Professor Olayinka Omibodo, who is the principal investigator for this project. Thank you.
Thank you, Dr. Rita. Just a fascinating array of papers, giving us such depth insight into what it feels like across Africa, plus such commonality with all the other centres. It's been an absolute walk through such stuff, and our last paper gives yet another perspective, that of the healthcare providers. So it's a real privilege to invite the team. I'm not sure who's presenting, but it's Shanae, Dr. Jane Kelly, and Dr. Hlomo and Galasa. And their talk is called "You Cannot Be That Nurse You Used to Be," and some reflections of healthcare workers providing services to adolescents and youth living with HIV during the COVID-19 pandemic. And hopefully we will then have time after this talk for questions for everyone. So while you're listening, could you also prepare all your talks for the chat? Thank you. Jane, are you presenting? I see you've put you're on mute, but we're not hearing you. Any luck with Jane? Diana, can you help us all? Maybe make Jane a co-host? We don't have your sound, Jane. Can other people hear Jane? Is it just me?
I can't hear you, Jane.
No, we can't hear you. I can see you saying sorry. And you're the last speaker. Is there someone else from the team who is on?
I can try and do it. Jane, there you go. Are you there?
So I think you might be hearing me or Jane. I'm not sure if you can hear me.
Yes, we can hear whoever me is. Me, we can hear. It's Jane we can't.
Okay, while Jane gets that sorted, Shame, she's also trying to step in for me. Hi everyone, it's Shanae speaking. The Eastern Cape has had a massive power outage, and so we have very limited signal. So I'm not sure how clear this will be.
Can you start in, Shanae, and take it off for us?
Yes.
Great.
Great. So just to start off with a presentation outline, Jane, you can skip to the next slide if possible. I'm wondering if she can hear me. Great. So in terms of the outline today, we'll give a brief intro on our team, a general introduction to the study itself, a brief outline to the methods with a focus on the key preliminary findings and possible implications for this really interesting study, and one that's come out of a really difficult year, but has really shown incredibly rich data. You can go to the next slide, Jane. I'm not sure if you can hear me. Jane, if you could change to the next slide. Awesome. So in terms of our team, we have the qualitative lead and research design and management team, made up of myself, Shanae Glinsky, Nontokozo Langwenya, and Lulama Sidoi, as well as the qualitative think tank, which was made up of various members of the team, including Ilona Tosca, Leslie Gittings, Christina Lorenzi, and our super crucial data collection and research implementation team, including Bongiwe Saliwe, Babalwa Taleni, Amanda Mbiko, and Pumza Belem, with analysis being taken on by Jane Kelly and Hlogoma Mantla Laza. I'm so sorry if I butchered your name, Hlogoma. It's a tricky one. You can go to the next slide. Thank you. In terms of background, the study definitely came out of a need to respond to the context, and in light of the COVID-19 pandemic and the associated lockdown, as well as the restrictions in place, the Hey Baby team designed an alternative set of research activities to take place in 2020 and potentially in 2021, including taking into account factors that factors such as healthcare provision can impact the outcomes of adolescents and youth living with HIV, including HIV treatment outcomes and mental health, for example, and also that during COVID-19 pandemic, health service delivery has been disrupted globally. This study aimed to get an idea of those experiences and what needs adolescents and youth living with HIV possibly had during this time. In order to do that, we decided to consult with healthcare workers in the area, and also embrace the idea of healthcare worker perspectives on what might be needed by adolescents and youth living with HIV during this time. So originally the plan for 2020 was a second wave of Hey Baby data collection with questionnaires with adolescents and young people, clinic file extraction of data, and child observations. However, our adjusted plan included a shift to qualitative, semi-structured interviews with healthcare workers in the Eastern Cape, exploring their experiences of service delivery to adolescents and young people during COVID-19. The way that this fits within Hey Baby is as an adjunct study and with the aim of informing future supports, highlighting the services available, the adaptations and adjustments that healthcare workers make for adolescents and youth living with HIV, as well as highlighting areas of resilience and ingenuity or creativity by these healthcare workers, and potentially areas for further support within these. Thank you, Jane. You can stop. To highlight the importance of this, there's great awareness that healthcare workers potentially play a crucial role in adolescents and youth living with HIV pathways to services. Therefore, by understanding the experiences of healthcare workers, we can in turn inform ways of supporting them. We also then indirectly support adolescents and youth living with HIV. In terms of our methods, this is very much one of the most interesting aspects of the creation of the study, is this idea that we were creating a study while in the midst of it with an evolving process. And so we really focused on an iterative and collaborative process, designing our research tool, which included English and English, as well as Xhosa versions. English is a mixture of English and Xhosa, which is most commonly used in the area. And also really integrating role play, feedback, adjustments, and further role plays within the team, especially highlighting the RA role. In terms of the kind of next process or next step to this process was the remote training of our team, who had to drastically shift to not only remote work, but also remote training, and as well as shifting from a typically quantitative style of data collection to qualitative research methods. This included the idea of engaging in what was important for remote training, such as methods, etc., but also navigating that space. I'm so sorry. There might be some noise behind me. I'm in the middle of the road. I'm so sorry.
Just carry on, it's fine.
To take over.
Just carry on, it's fine. You've only got 4 more minutes, so don't worry, just carry on.
Okay, so I'm going to step back and hand over to Jane and Hlogoma, because I do feel like the process of training this team is in itself a presentation. But I do feel like the importance here is our findings and the incredible data that's emerging so far. Jane, can I hand over to you?
No, we can't hear you, Jane, sorry.
Okay. Would you like me to carry on? Jane, I can read your slides for you.
Yeah, do that. So sorry, but
no problem. I'm happy to
hear the findings, and we've only got 3 minutes
Yes.
left of your talk. So internet
speed
is
it
with us this time. Yay.
Great. So in terms of preliminary findings, I'm sure Hlogoma will have more to add here, but briefly looking at some of the first few that have come up are around stress and anxiety, as well as a sense of guilt. Thinking about this idea of going the extra mile, as well as what do healthcare workers need and suggestions for adolescent services. Next slide, please. Thank you. So physical and emotional exhaustion was extremely prevalent in most of our interviews. And I think that's quite expected in the context, but this sense of guilt that also permeated many of them was quite an interesting find, as we found that healthcare workers struggled with the idea of fearing their patients and not wanting to get sick or be contaminated by their patients, while with the intention of protecting themselves and families, while knowing and wanting to serve patients as they always have.
Sorry to interrupt, Shane. I just wanted to check if you can hear me now.
We can hear you.
Oh, amazing. I know, I'm so sorry. I'm so sorry, everyone. I've just quickly joined on my phone. So let's try and rush through the rest. Thank you, Shane. Apologies, everyone. Okay, I think, Shane, did you manage to cover the slide? Should I move on to the next one?
Yes, you can.
Okay, great. Sorry about that. Okay, so what we found that was quite interesting is that while these healthcare workers clearly experienced a lot of stress and a lot of anxiety, there were also these very clear examples of how they went the extra mile. One example of this is taking initiative. So a particular healthcare worker said, since we heard about Corona in the media, what we did is we formulated a committee known as the Response Committee. In that meeting, we asked to have a tent outside for patients. So basically, we developed a flu clinic at the back. So we're taking them directly to the flu clinic so that they can test there. Another example that stood out is actually being available to their patients 24/7. So this healthcare worker said most of them they've got my phone number, they use it 24/7. So it's like a local emergency number if things get serious so that I can be of help. And another example of going the extra mile was making sure that their adolescent patients received medication. So this healthcare worker said if they don't answer their phones, then we do tracing via community health workers. Then we've got a tracing letter so that community health workers should address straight to that person, and then the community health worker should handle that letter, and they come, you see. So these were some really nice examples of how, even though the healthcare workers were faced with a lot of stress, anxiety, and guilt, they still were able to go the extra mile for their patients. I'm now going to hand over to Hlokoma to quickly take us through the next 2 slides. Thanks, Hlokoma.
Okay, so I'll talk about what do HCWs need. So basically, there were professional and personal needs. So basically, the personal needs were related to psychological support and emotional support. The healthcare workers talked about how there was no support for psychological support for them as healthcare workers, and also there was no emotional support. So therefore, well, from work, that is. So they had to find their own coping mechanisms, such as joining WhatsApp group as professionals or with family, and just trying to find ways that they coped at home, like doing exercises and just interacting with families and visiting family. They also talked about how they could not perform to their full potential because they were scared of contracting the virus. So they said, yes, you have to render a service, but you are scared, meaning that even the person you are giving a service to, you are not doing it as you're supposed to do, because they were always scared that they might contract the virus. So professional needs were related to working equipment such as protective gear. So they also talked about how they were not really equipped in using their protective gear in order for them to curb infection control. So they talked about how they still needed capacity building in the context of PPEs that we are wearing. So they talked about how they still could not, we're not sure how exactly to use the PPEs. One example was the right mask to use. So there were 2 different types of masks that I might have forgotten the details of now. So, but there were 2 different types of masks. So there was another one that was more appropriate to use than the one that they had available. They also talked about the lack of human resources. So for instance, when one of their staff would get ill or would be off work because of the high numbers at the facilities, they would also not be able to have enough human resources. And this was also related to when they had to give out medication. So they talked about how they did not have pharmaceutical human resources that would help to distribute the medication. So they had to distribute medication and also attend to sick patients. They also talked about limited work equipment. So they talked about how during this time of COVID, they had to use the same BP machine, for example, to examine patients, which they found that it was not safe, as it would be easy to contract the virus. Next slide, please, Jane.
Sorry, Hlokoma, I'm just going to quickly jump in there because I'm aware, Lorraine, sorry, we're already 3 minutes over time. We could finish with this slide, or if you want to stop now and we'd rather break for questions.
Thanks. You've had such challenges and we've given you a few extra minutes. Okay. Let me just wrap the slide up and very briefly, everyone's read it and it's just such fascinating data. And then we'll get our audience a chance for questions.
Great. Okay, thanks. Thanks. Over to you, Hlokoma.
Okay, I'll just be a minute. So then we also had suggestions for data for adolescents. So the HCWs talked about how they also would have loved to improve services given to or provided to adolescents. So they talked about awareness raising at schools because adolescents had a habit of defaulting on medication. So they talked about information sharing, awareness at schools specifically for teenage boys. Girls need to act responsible when it comes to taking medication, and also they also had a habit of defaulting. But they also talked about how they did not necessarily give prevalence or preference to HIV negative patients. All patients were treated the same, especially when it came to adolescents as well who would visit the clinic. So emotional support was really needed when provided to the adolescent people or young people, as they would reach out to the healthcare workers, talking about their fear of losing guardians, or let me say guardians, as they had already lost relatives to HIV. So these were mostly HIV positive adolescents who had previously lost parents, coming to the healthcare facility for. Okay, let me disconnect. It shows that my internet connection is unstable. So adolescents would come to the clinic for reproductive health and family planning. So they still did that. But they also talked about how it was still difficult for the adolescents to access healthcare services because they did not have a designated space for them. So they would spend longer hours or longer periods of time having to wait for services. So they suggested that there would be a designated help desk just for the youth, or a nurse that would be designated to the adolescent people. This is because the adolescents would most probably not want to come to the clinic and then end up defaulting in medication because of these waiting periods. So they also suggested that medication be delivered to the adolescent people. Thank you.
Right, lovely.
Thanks very much,
Thank you very much. That was just fascinating. So now to our wonderful silent and patient audience, we've got some time for questions, which can be to anybody on the panel. And if you don't feel like talking, please just pop something into the chat and we'll read them over. So Nontokozo, do you want to kick us off? Do you have anything to ask?
Sure, thank you everyone for the presentation. I think I'll ask a question related to the work presented by Kate. And Kate, it's been very fascinating seeing how the different governments respond to supporting the population during this time. And I think one of the ways to see if this is successful is thinking about access, right? So there's been a lot of conversation around whether or not the extension of different services is resulting to an uptake of those services within the population that needs it, because there are less people in the government offices. So my question is, how are you thinking of monitoring this changes that have been made to kind of measure whether or not they've been powerful in mitigating the social impact, the economic impact, of COVID-19?
So I think there's actually been amazing work done in South Africa by Saldry at UCT. So they've been using a survey called the NIDS-CRAM survey. So they had a nationally representative panel study, it was a study of people over time, and they used that as a sampling frame to phone people. And it was the best way, even without doing face-to-face field work, that we could get a sense of what was actually happening. So they've got I'll find the evaluation and I can send it, but it was showing that the extension of the child support grant, the pension, and the increase, so the increase in amount of the child support grant and the pension, and then extending the new COVID unemployed grant. So that, I think that there were a couple of million people who didn't fall into food poverty because of that. I can't remember the exact figure, but I'll find the evaluation. I think that's actually been one of the few that's been done in the world, because it's been really hard to do survey field work, but they were managing to do it over the phone. But it was really striking how important even that small amount of money was during this time. I'll look for the evaluation now. And so they've extended, as a result, the presidency has extended the unemployment grant until December, but it's unclear what they're going to be able to afford to do after that.
Thank you, Kate.
Great. Any more questions? Just feel free to put your hand up, raise your hand, and I'll see it on the participant list. I had a query for Dr. Rita. What's happened with the mental health services now? Are they opening up, or is it still very difficult to access mental health services? What's happening at the present?
Okay, thank you for the question, Lorraine. I think presently the lockdown has been eased because of we have had a gradual fall in the prevalence rate or in the incidence rate. So presently the wards are open and we are having a normal consultation with patients, but with preventive measures as usual, face masks, social distancing. But the lockdown has been eased and mental services are now accessible.
Great. Lucy, you have a question?
Hi, everyone. I wanted to first of all say this has been absolutely fascinating. I can't believe that an hour and 45 minutes has gone and I've just been paying attention to every word. It's been brilliant. I had a question for Rachel and Yvette about the child marriage challenge. And I've seen a lot of kind of raising of this as an issue. But what I was wondering is this, you know, and of course this hub is thinking about accelerators and simple packages of interventions that can have multiple positive impacts. What would be, you know, if you had two things that could be done across Africa that would reduce the rates of child marriage during this COVID period, what would they be? What would the evidence suggest that they should be?
Yvette, shall I go or do you want to go?
Kathryn, I'll continue.
So I think the evidence is very strong around education and getting girls back into school post-COVID is very strong. But whilst there's a lot of association between child marriage and education, the causality is a bit confused. I mean, girls drop out is a cause and consequence of child marriage, but I think there is strong evidence that the longer girls stay in school, the greater chance there is of delaying marriage. So I'd say that would be one. I think with COVID as well, there is some emerging evidence about, you know, the economic impacts and therefore the need for sort of social protection packages that benefit households with vulnerable girls. And there is growing evidence, but I think there's less evidence on the combined packages of the sort of cash plus interventions, which I know we're all interested in, about how do you ensure that you mitigate the economic impacts of COVID on families to stop girls being married off early, and combining that with some of the social norms interventions as well. So I guess cash and education would be my two biggies, some of which is better evidence informed than others. But Yvette?
Yeah, so the question to ask yourself would be, why does child marriage happen? So the drivers that cause child marriage to happen even without COVID are still the ones that have been exacerbated now, where we have lack of access to education, which has been outlined by Rachel, and poverty as a driver for child marriage. So the solution being then economic justice for girls with cash transfers as an opportunity. And then looking at how do we create multi-sectoral approaches so that the issue of child marriage is captured in other sectoral responses. In health, when we're talking about the need to provide contraceptive for adolescents, for example, when we're talking about the need to ensure that adolescents have agency for their own bodies and rights, so that we are looking at a solution that is also input into other programs that are working on ending gender-based violence in totality.
Thank you, really helpful.
Great. I don't see any more hands, but I wonder if, Kathryn, you'd be prepared to comment on how this child marriage work that Yvette and Rachel are talking about, how that resonates with teen fathers, because this is all about girls, but what do you, just some comments from the teen father point of view?
Yeah, kind of, I'm not 100% read up on the literature, but it would be interesting to see kind of how this potentially unfolds and kind of what kind of programmatic responses can be put into place there. Obviously, kind of when we talk about kind of child marriage, we talk about adolescent girls, and it'd be interesting to see from kind of Rachel and Yvette as well, of whether there is any data coming out around kind of adolescent boys as well in terms of child marriage, or is it purely focused around adolescent girls?
And maybe just quickly to respond to that. So UNICEF have actually produced some data last year looking at the prevalence of boys who marry young, and we can share some of that data with you after the call. But I think also there's a growing interest in sort of looking at seeing men as champions and boys as champions around tackling early marriage, but also being supportive when girls do marry early. So I think Promundo and some of the work of across, yes, Sonke, thank you, have been doing quite a lot of work around this. So I think a lot of the Men Engage work across Africa is very relevant to child marriage work as well, which is probably where you're linking in as well, I would guess.
Kind of, and sorry, I'm just kind of thinking out loud as we're kind of going forward, but maybe as kind of a follow-on from Lucy's question, kind of in terms of potential accelerators and kind of programmatic responses to jump on the back of, would you say that kind of cash and education would be kind of similar in terms of engaging adolescent boys within kind of these programs as well, and kind of promoting the impacts there around child marriage, or does that look different?
To be honest, I think there's been less research looking at the drivers of boys who marry early. I don't know if Yvette, you've seen any sort of particular Africa studies on that, but we have much better evidence base on looking at girls who marry early, because obviously the harmful effects of early marriage and pregnancy, that's tend to be where the greatest focus has been.
Yeah, so just very quickly, I would add then the importance of looking at the health element when it comes to boys, because then if you're able to prevent the pregnancy, which is a driver of child marriage, then we'll be able to reduce some cases of child marriage.
Yeah, completely. And I suppose where the adolescent father literature comes in there is around kind of what happens when they are potentially fathers, and kind of post that prevention stage, kind of what can we do to kind of assist at that point.
Where the economic justice angle then is very important.
Yeah.
And the accelerators also point to the fact that the quality of care is very important, the clinic side. And maybe Shanae or Jane Oklokomo could comment, did you have any idea of how the healthcare workers could respond particularly to teens? And was the quality compromised? And what do you think our teens might say if they come into contact with the kind of healthcare workers who you described?
Sorry, Lorraine, I missed the first part of the question. Would you mind repeating it?
Just saying, the other side of it is that care, the quality of care is so important. We know that from the accelerators. So wondering from your insightful research, how you think both teen girls and boys may have been affected by the quality of care by these stressed out healthcare providers.
Look, I think it's a difficult one to answer because we obviously didn't interview the adolescents.
Oh, we've lost you. Oh.
Am I back?
You're back, yeah. We're desperately,
technology is not on my side today. I think it's a very interesting question, Lorraine, and one that I can't quite answer, I think, because we didn't ask the adolescents themselves. Yeah. So it's a difficult one to sort of, and it's also not something that we directly asked the healthcare workers. So sorry, that's not quite an answer. Yeah. I think it's just based on our data. It's not something that we can give a firm answer to, but I don't know if Shanae, if there's anything you want to add to that, if you're still around, if technology is on your side.
If I could jump in briefly, Jane, and everyone
Thanks,
else.
Elena.
Sorry, this is Elena, maybe just doing what my brain does, which is linkages. Our tag team, I don't know if anyone from the tag team is here today, has been interviewing young people. And one of the things they find is that they're just this additional layer of stigma attached to being seen outside facilities, having to sustain or follow safety protocols has made accessing services a bit harder. So not even getting to the quality of care yet, but even not going to facilities because of self-stigma. And the numbers of things like HIV and TB tests have really gone down. Certainly based on NHLS data in South Africa, which is what another student, researcher in our team has pulled out. I don't know, Lorraine, they're markers of care access, I suppose, not of the quality.
If I could jump in as well. Hi, everyone. It's Leslie, and we'd be happy to share findings at a different time from our TAG team, which I think align really well to the Hey Baby work and what Alona shared. We've also found that a lot of the issues that exacerbate adolescent access in the first place, like shouting nurses or feeling like they're being scolded, have become intensified. So that's something that we've been hearing as well, alongside not getting the same type of attention. So not being able to show up in your uniform and going through a slipstream queue, for example, and additional wait times being an additional barrier for them too.
Yeah, so all this discussion is really about quality. I wonder, Kate, in the provision, anyone has looked at quality of the service? Much of what you were saying was just providing the service, but does anyone look at, is it a good service? Because that's one of the accelerators that we're looking at in the Zafuni data.
So, I mean, I think one of the major advantages of cash is that there's not a lot of variability in quality. So, you know, there's variability in whether people can access it who are eligible, but once you get it, it's fungible and it's easy. So it scales really well. And I think that's why a lot of people have gone for cash grants. In terms of access, I know the South African case the best, and there may well be some issues with access given how fast they rolled it out. So I know that the Treasury was doing their projections based on a larger number of unemployed people applying for the grant than actually did apply. And there were some issues with, they merged data sets very quickly to figure out whether or not people were eligible. And there were some issues with people who were actually eligible being excluded. So I think quality definitely was an issue, but the argument we were making was, it's better to have something than nothing. And if we wait for a perfect solution in a rush, we're going to delay a rollout, and actually, getting 60% of the way there can do a lot of benefit. And we were even saying, some money will be lost, there will be some corruption, but we should just allow for that. It's still better than not doing anything. And I think certainly from the cash side of things, it's very hard to think about how one does harm. It's only about how much good you're able to do, basically.
Yeah, I wonder if Stefanie is still on the call, because she's actually looking quite specifically in the middle of the data at quality. Stefanie, do you want to add a brief sentence before we finalize and end this fascinating meeting? I can see you there, but you're on mute. Maybe not. Okay, well, let's turn to Nontokozo to say some last words before we close. Thank you so much for co-chairing so admirably.
Oh, thank you so much for the opportunity, Lorraine. So thank you so much, everyone, for the presentation today. I think it was quite great to be reminded as well about the fatherhood component. I think in sexual reproductive health, we do tend to focus a lot on the girls, which is given the research, but it is very nice to also think about fatherhood and how that looks like. And most importantly, to also note that the economy is a driving factor for a lot of our access to sexual reproductive health, and a lot of the outcomes that are linked to poor access to the services. And both from the client perspective and the work from Shanae from a healthcare worker's perspective. So we thank everyone for taking the time to prepare, and we hope it has been a very insightful presentation for everyone. It has been for me. Thanks, Lorraine.
Great, so it only leaves me to say there's been enormous organization underneath it, and Diana's been working tirelessly with the team. And that's what makes it run smoothly. IT has conspired against us today, but we're fine, and we got almost every droplet of gold dust that we wanted. Our next webinar will coincide with our annual meeting, and it will take place on Thursday, the 4th of February. And we have a very high-level panel, once again, amazing speakers. So we look really forward to everyone joining. And just thank you all for spending so much time hanging in there. Our audience numbers have stayed very static. Thank you for the wonderful questions, but even more for the wonderful answers. Let's all put out our cameras and wave, so at least we feel we've seen all these lovely people who are there with us. Oh,
and
Jane,
thank you to Lorraine for masterminding, planning, and organizing this.
Good. Oh, I can see. Oh, it's so nice to see everyone. Maria and Ilona. Half of Rita's head we can see. Helena's there, and Katie. That's better, Rita. Oh, Mona, hi. Oh, this is horrible. Somebody please get rid of COVID. We really would like an in-person meeting next time. Lovely.
Thank you, everyone.
You're there.
Bye, everyone.
Thanks all.
Bye, everyone.
Okay, bye-bye, everybody. Thank you for being a wonderful audience. It's a skill in its own right. Bye.